Morning, everybody. Morning. Y'all take a little quiz this weekend?
Small little quiz.
I hope it went all right. So how many of y'all read for this section today? Oh, Patrick, did you really read for this?
I read Cameron's. I read school.
I don't expect too many of y'all read for this today. All right, we talked about anorectal abscesses and fistulas, and when we do, the vast majority are cryptoglandular, which means they involve the glands in the anal crypts as sources. Other fairly common causes of anorectal abscesses and fistulas are Crohn's disease, and anal fissures can contribute to fistulas. But when you're taking a quiz, they're generally going to be talking about the cryptoglandular ones. Nobody has a real good handle on the frequency of abscesses and fistulas. Estimated about 100,000 per year in this country. Occurs in people ages 20 to 60, most commonly. And men are twice as likely as women to get fistulas. And as far as the etiology and here, when I see patients in the office with abscesses and fistulas, frequently get around, they ask, what caused it, and of course I can tell them cryptoglandular stuff and that. But the question they're really asking is, what did they do or what did they not do to get an abscess or fistula? And as we talk about this and see that they're can be pretty devastating, I tell them that if I knew what you could do to not get an abscess or a fistula, I'd be doing it. But I don't know what to do or not do to get an abscess or fistula. It's not just necessarily hygiene related or special diet related or anything. Unfortunately, they just happen. So, I hate when keyboards move around. When you look at the rectum and the anal canal, there's a junction here, the dentate line. This is rectal mucosa, and this is skin. And then this is transitional tissue or mucosa, and it's squamous but doesn't have hair appendages. And these are little crypts, the crypts of Morgagni. And in the base of the crypts are a little gland right out here, and it sits between the internal and external sphincter. Internal sphincter, external sphincter. And the current theory, and I haven't seen anybody question it, particularly is that this gland gets obstructed, there are bacteria, and out here along this track it develops an abscess that will then go on to seek a point of least resistance. So there are about 8 to 10 of those glands. So if someone gets a fistula, they're not immune to getting another fistula, they still have glands. And again, the gland gets infected and goes to the point of least resistance. The areas of least resistance are fat, these yellow areas. And there's subcutaneous fat, and then above the external sphincter muscles where they're attached to the pubis and the coccyx, there's a deep layer of fat, and this area posterior, the deep postanal space, is one of the more troublesome areas that we get abscesses, that we deal with these, and I'll talk about that a little bit later. But getting an infection in this area, this communicates with the fat on either side of the rectum, the ischiorectal fat. And so this deep space is where horseshoe fistulas or abscesses come from. They wrap around the anus and sometimes go essentially 360 degrees around the anus. So how do people show up? Pain. That's the most common reason that people show up is they hurt. The pain is pretty constant. not necessarily related to bowel movements. And I have to ask a few questions, so I won't ask too many, but start back at the back, somebody among the interns. What causes anal pain? Etiologies. Abscess is one, so you can't use that one. What's something else? Fissure.
Hemorrhoids,
What kind of hemorrhoids?
external,
What kind of external hemorrhoids?
thrombose,
Thrombosed hemorrhoids. What else? All right, you covered about 99% of it. So when someone comes in saying they're having anal pain, you're looking for an abscess, a fissure, or a thrombosed hemorrhoid. Now, some people, their descriptions of pain you have to work with, because sometimes it'll be irritation, they can have an external hemorrhoid that gets irritated. Sometimes when they talk about pain, they're actually having itching. But their perception of that is on the spectrum of irritation, and so that's pain. But if someone comes in saying that they really hurt, abscess, fissure, thrombosed hemorrhoid. So if you look and you don't see a thrombosed hemorrhoid and you can't see a fissure, you better start trying to figure out where their abscess is. So, and they'll be pretty consistently hurting. Fever, not real common. Malaise, yeah, it's kind of hard for me to tell someone has malaise when I see them, especially when they come in hurting. They all look like they don't feel good. Sometimes they'll have purulent drainage out of the anus. On physical exam, they have fluctuance, tenderness, and about half the time it will already have drained spontaneously. Excuse me, that's not half the time. It'll ultimately be a fistula, but sometimes they'll come in and it's already drained spontaneously. They already have a fistula with their abscess. And so how do you diagnose it? History and physical. It's always a good starting point. The pain, be constant, take a look, and most every time you diagnose it. Here, and as in most ERs, it seems like they're mostly diagnosed by the initial screening CT scan that they get. You know, how when they go and register, they run them through the CT scanner on the way to the room. It's remarkable how many perianal abscesses are diagnosed with CT scan, which is scary. CT scan is really not very helpful. If you're trying to figure out why someone is having anal pain, CT scan is not on your list of things to look for. MRIs can be helpful. MRIs give much more definition to the muscles and the fat planes, and the T2 weighting, which I have no idea what causes the T2 weighting, shows inflammation, and you actually see fistula tracts. They talk about it a lot in the literature. Translating that to your physical exam and looking can be easier said than done for me. And then anal canal ultrasound, and I used ultrasound for a while looking at fistulas. Wasn't very helpful for me. They're certainly ultrasound's an art. It's not a very good science, and it's not one of my good arts, at least not for fistulas. I can look at the muscles pretty well and look for sphincter defects, but not for fistulas. But if someone's talking about it, and especially on test, they may ask about ultrasounds and MRIs. Differential diagnosis. I saw a patient that thought they had an abscess and had a little epidermoid inclusion, sebaceous cyst. That's pretty easy to evacuate it, they're better. Hidradenitis, we see a good bit of hidradenitis. They'll have lots of draining sinuses and abscesses, but generally don't communicate with the anal canal. Hemorrhoids, pain, so that's where that comes in and looking. Pilonidal disease, I've seen plenty of times that pilonidal disease was confused by anorectal abscesses. And then Bartholin gland abscesses are common, and it's remarkable how many times these end up getting drained and result in a rectovaginal fistula. I prepared one of those last week. So classifications, and I'll show a picture. You have to figure out where the abscess is. It's either in the subcutaneous tissue, perianal. It's usually fairly simple. Ischial-rectal is in the fat adjacent to the anal canal, deeper fat, and that's when it wraps around from posterior, that's a horseshoe. Then intersphincteric, that's between the internal and external sphincter. And then suplevator. And suplevators tend to come from two sources. Either it's a bad cryptoglandular anal rectal abscess that is tracked up between the internal and external sphincters to the fat above the levators, or more commonly, it'll be something intra-abdominal, diverticular abscess, pelvic abscess, some type of perforation of the rectum that's caused an abscess. So suplevators are very complex. So again, you can get perianal, it's just down this fat. I don't know the name of this connective tissue here that separates these, but it tends to be present. But a little superficial, this can burst through and become into the ischial-rectal space, or it can be from a direct communication this way. So either this goes up or this comes across. This is the intrasphincteric, and then the suplevator. Here are the levators coming down. They form the proximal part of the anal sphincter, and these are the muscles that give the support to keep everything in the pelvis from falling out on the ground. So treatment. Antibiotics, no, not necessarily. Use antibiotics, valvular heart disease, and that might even be in question today, but probably not going to get in trouble for putting a patient on antibiotics if they have bad heart disease, valvular disease. Immunosuppressed patients, this is where I use antibiotics. If the patient has a lot of induration or cellulitis associated with their abscess, I think they get better a little quicker if you have them on antibiotics afterwards, but they need to have the induration and all with it. And diabetics need antibiotics. In the treatment, the role of fistulotomy, or primary fistulotomy, you get there, you drain the abscess, and you find the fistula, do you address it or not address it? I tend to address them if they're straightforward and easy to find. And if you sit there and start trying to figure it out, I don't know, I can get the fistulas a little further down, but those of you that have done fistulas with me, you take that probe and you start putting it around. I describe it kind of like picking a lock, trying to find the right tract and hole, because it's not just this big wide superhighway most of the time that the probe falls into, but it kind of meanders. And if you have an abscess cavity this big and trying to find a little pinhole out the side with a probe, probably not going to be very rewarding. So you don't knock yourself out to manage the fistula at the time of the primary surgery. And if you're taking a quiz and they ask about it, it's probably plenty safe to drain it. Cultures, used to culture them all the time. Don't culture nearly as often as I used to. The primary reasons to culture is, one, if there's a question, is this truly an anorectal, cryptoglandular anorectal abscess, or is this just a skin abscess, a boil? And we're seeing a lot of staph infections these days in patients that get recurrent buttocks abscesses and whatnot. And if you culture it and you get a single organism of strep, then it probably does not communicate with the rectum. But if you get a culture in this multi-organism, then it's probably an anorectal abscess because of the communication with the GI tract. And then if you have the leukemia patient or someone like that you're draining an abscess, culture them, because ID is going to want to have specific antibiotics to use. And one of the reasons it's not generally required is the vast majority of the time, patients treated and gone home before you ever get your culture results back, and so it's just of no benefit. So the treatment, drainage and drainage and drainage is really pretty simple and straightforward. Most of the residents have heard me pretty frequently. I have a basic philosophy on anal rectal abscesses is if you have to pack it post-op, you didn't drain it. How many of y'all have ever packed a post-op anal rectal abscess? Okay, how many of y'all enjoyed it and thought it was very rewarding? Besides Miles, the sadomasochist in the group. I mean, it's hard. And if y'all have a hard time doing it, think about how good a job happens when the patient goes home and they have their third cousin packing their wound. It isn't happening. So drain it so that even I could take care of it, which means I'm lazy, I'm not going to do anything. You know, all they got to do is get in a tub or get in a shower. That should be all of the post-operative management they need is either a tub or a shower. So you don't unroof it to the extent of taking the sphincter muscles. So don't be stupid, but skin is cheap. Buttock skin, you know, once they've had an abscess, they're not going to make a living being a model showing off their backside. It's just not going to happen. They've lost their chance. But that skin will all grow back. If you do hidradenitis and you take off areas of skin this big, it'll heal back. It does not need skin grafting. So if it's, just take the skin. They can be okay. So if you have an abscess this big, take this big, not this big, because they won't heal. And I see a fair number of patients that get recurrent anal rectal abscesses that I can't find fistulas, and I think it's because they weren't drained well the first time. And they healed over and they came back. Try to keep your incision close to the anal verge. You know, instead of draining it 3 feet out from the anus and having a big long fistula tract later, shorter tract. Drain it near the anus, but not in the muscles. So it's pretty simple. Now, caveats. If a patient has a big issue of rectal abscess or a horseshoe abscess, and you're going to be talking about taking off giant hunks of skin, now you don't have to just prove something to me about how much skin you can take off. If it's gigantic, again, don't be stupid. You make 2 or 3 smaller areas and take large 1-inch pin roses and put as a loop from one hole through the abscess to the other hole, suture them together, and leave them. And leave them, and leave them. Someone recently, we put counter drains in, and in the clinic during the past month or so, someone took the drains out at 3 to 4 weeks. So 2 weeks later, I got the privilege of putting drains back in clinic. If you put counter drains in, I told Miles yesterday, there's no way that you're taking them out while you're on the rotation. You know, so rotations last up to 3 months. So. Generally, they can leave them about 3 months or so before you take them out. So it's no big rush. You want to let all that collapse. So sometimes drains are appropriate, but again, I can take care of those at home. Sit in a tub, take a shower, and that's it. It doesn't require anybody packing them. And then the other choice is for some really deep abscesses is to use a drainage catheter. And I quit using Malincots a few years ago. Students may not be familiar, hopefully y'all are. There are drains called Malincots that are rubber drains that come up, and they, at the end, is like a little basket of rubber that's larger than the drain to kind of hold it in place. What I started having trouble with, and I had not had trouble before with it, was ingrowth of tissue, and you can't pull it. And you don't want to break it and leave a foreign body. And I've taken them to the operating room and taken a Bovie to cut them out. So I quit doing that. Justin, you're nodding your head. Have you seen that before?
There was a guy that, there's more.
I'm sorry, you're chewing too.
He didn't come back for his follow-up, but he showed up like 4 months later with a tail, and he had to go to the operating room. And have
Yeah,
it out.
okay. I use a Pezzer catheter or mushroom catheter now. Again, it's rubber, the end's larger than the rest, but it looks more like a spaceship saucer at the end, and it just has 2 holes to drain, and I have not had one of those grow in yet. Yet being the operative word. Okay, so you have a small perianal abscess, and you drain it, and you make an incision about this big, not stab it. Now, if you're in the emergency room, you know, yeah, you can decompress it, but then get them to a setting where you can go and open it up. But in the operating room, take off the skin. Now, when you get into the perianals, like I said, remove the overlying skin in the horseshoes. And somewhere in here I have a picture, and I'm going to show you. But you can drain those large abscesses laterally, and usually with counter drains. Often the ischial-rectal space, I mean, it's a big space. And so often those are going to require counter drains, and you have to do a posterior fistulotomy. Intrasphincteric, the abscess is between the internal and external sphincter, and you start in the skin and the anoderm, and then just open the internal sphincter all the way up over the extent of the abscess, and it drains basically internal. And suplevator, again, these are tough, and there is a key issue to remember. If it's from a primary cryptoglandular, you have an ischial-rectal abscess that has perforated the levators, drain it on the skin below. If it's something from above, a diverticular abscess or something like that, drain it from above a higher. The texts talk about draining them through the rectum, but today with interventional radiology, more often you can drain it external, like parasacral or through the abdomen and down to it. But you don't want to drain it through the skin, because then you get a big fistula outside of the whole sphincter complex. So, drain to the skin, and abscess here. You just start right here in the intrasphincteric groove and open it all the way up to here. And just take it off. You're okay cutting the internal sphincter. And then abscess up here, actually is probably best drained right along this track. Not necessarily into the rectum, because now you can have a fistula from whatever caused it to the rectum, and that's going to be a low fistula. So again, intrasphincteric through the intrasphincteric groove, cutting sphincter, transsphincteric, you can drain to the skin, and these are the fistulas, excuse me, keep me on track. Yes. Classification of the fistulas. Let me just go to the picture here. You can have a simple or superficial fistula tract. Just comes down and doesn't involve much. These you usually see from anal fissures, where they've undermined and made a little abscess. Intersphincteric, you have the abscess and it's drained down through the groove. And low transsphincteric, those are the 2 most common fistulas that we see. And the fistulas occur after drainage. And then this is a suplevator from perianal disease gone wild. And this is from where someone has mistakenly taken an abscess and drained that started here and drained it out here on the skin. And now you have all of the sphincter involved in these 2, and that's a bad deal. On your question, Patrick, on the quiz, I hope they weren't looking at one of these 2 and asking you to use a cutting C-time. I don't know what the question was, because these you fix by repairing, but I'll get to that.
It
It
said
said what type
seton
of-
is the appropriate treatment for which type of
fistula.
fistula, and it had like transsphincteric, intersphincteric, and then some other, like a superficial one.
We'll get onto it later. Time is running short. All right, so the treatment is by fistula classification. As the question sounds like it was alluding to, and I'll go through them real fast, but Goodsall's rules, especially for the students, because it doesn't always apply, is if you have this is the mid-sagittal plane, this is anterior, this is posterior. If you're anterior to this, usually you have radial fistulas. If it's posterior, it's usually from the posterior midline in that deep postanal space. And if the fistula is really far out, it's usually posterior, looking back around here. The goal is to preserve sphincter, don't cut the muscles. So I can go through these pretty fast. Fistulotomy, if it's low, you get excellent results. Incontinence up to 82%, I have not seen that. Incontinence rate's pretty low. Fibrin glue and fistula plug, I just put in there because they don't count for much anymore. So you just open it up over the tract, put a probe and open it. Cutting seton, you need to give it at least about 6 weeks to heal in. This is used for really more of an intermediate transsphincteric fistula. Usually patients that I've had complex or have failed on repairs before. And again, you put it in, and over time you let it cut through. And I've never seen a book that described it well. And advancement flaps, you go and you raise a flap and bring it over it like a window shade. You have a hole and you close it over. And I use these primarily on anterior fistulas. And it works pretty well, but has about a 20% failure rate. And not much incontinence, you haven't cut the muscle. Could not find a good picture of the lift procedure. This is the external sphincter, internal sphincter, and you go down between the two and ligate the fistula. And I do that on lateral fistulas most commonly. And then on the horseshoes, again, you get out here and drain. Usually make a hole here, put counter drains in, and then open the fistula tract into the deep postanal space. The muscles back there are hooked to the coccyx and they splay, so really when you cut it, you're more spreading the muscles. And they're not going to do as well. And just the CROHNS fistulas, I'm not going to address. All right.